Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. Here's Dr. Weiner.
Cancer surgery has come a long way over the last 10, 20, 30 years. Radical procedures used to be commonly performed. That was true in the setting of breast cancer. It was true in the setting of pancreatic cancer. A whole variety of different types of cancer were treated with very aggressive surgical approaches. And while some of these approaches are still occasionally used in highly selected patients, minimally invasive techniques have really become something that surgeons focus on a great deal. Joining us today is Dr. Kevin Billingsley. Dr. Billingsley is the Chief Medical Officer at Smilow Cancer Hospital and Yale Cancer Center and a professor of surgery at Yale School of Medicine. He is an expert in surgical oncology. Dr. Billingsley specializes in the surgical treatment of complex cancers, particularly gastrointestinal cancers and hepatopancreatobiliary cancers. That is clearly a very long word. He has a great deal of experience in cancer research, patient care, advancing surgical techniques, and helping us set up our systems so that we're optimally and efficiently taking care of patients. So it's great to have you here, Kevin. Welcome to Yale Cancer Answers.
Eric, thank you. It's great to be here. I've been looking forward to it, and I want to thank you for giving an opportunity to provide our audience with kind of new insights onto the evolving role of surgical care for the cancer patient.
Well, I think it's fair to say that apart from patients who have diseases like leukemia or lymphoma, that when we're talking about what is often referred to as solid tumors, which means breast cancer and lung cancer and various gastrointestinal cancers and sarcomas, that cancer treatment is a multidisciplinary approach, and it involves surgical oncologists and medical oncologists and radiation oncologists, and of course, behind the scenes, people like pathologists and imaging experts. So surgery, of course, is critically important, and for years and years, it was the only treatment that we had. So maybe first, just because I think this is a little confusing to a lot of people, there are many different types of surgeons that get involved in cancer surgery. And yet surgical oncology doesn't really refer to all of them. A typical surgical oncologist, someone who has trained in surgical oncology and is board certified in surgical oncology, what areas do those people specialize in?
No, I appreciate that question. And I think that, narrowly speaking, surgical oncology is that surgical practice that focuses primarily on the surgical treatment of the gastrointestinal system as well as soft tissue tumors such as melanoma and sarcoma.
And breast cancers, I think, as well.
And breast cancer. But as surgical treatments have evolved, techniques have become more sophisticated and specialized, and the multidisciplinary interactions that you have described have become more nuanced. Surgical oncology as a field is also involved. So really, in the current era, in places like the Yale Cancer Center, I think it's important to think of surgical oncology broadly, and a surgical oncologist is a kind of a technical expert in cancer surgery who has the broad background and training to understand cancer care in the big multidisciplinary context, as well as the set of kind of clinical and relational skills to work effectively within a multidisciplinary team. And that may include thoracic surgeons who specialize in lung cancer and esophageal cancer, obviously breast surgeons, people who do what I do, which is mainly gastrointestinal cancer. But even in gastrointestinal cancer, we have kind of narrowed our specialty focus to a group of surgeons who specialize particularly in cancer of the large intestine, the colon and rectum, versus people who do what I do, which is the upper GI tract, mainly liver and pancreas and stomach.
Sure. And for example, if a man has prostate cancer, he's typically not treated by a surgical oncologist. He's typically treated by a urologist. But what has also happened over the last, I'd say 10 to 20 years, is that there are fewer and fewer urologists who do general urology, a little bit of prostate cancer and a lot of other things. And there are more and more urologists who specialize in cancer surgery. So that I think that what we've seen in surgery in general for people with cancer is that it's falling to a small group of people who focus within their own field on cancer, and who are very comfortable interacting with the radiation oncologists and the medical oncologists. And of course, what's so important about this is that there are pretty good data that the more you do something, the better the patient does. And while there are exceptions, but that doing a large volume of the same type of procedure makes a difference.
100% agree. And I think, there are two pieces to this that I really want the audience to understand. One is practice makes perfect in surgery and virtually everything. And despite the fact that surgery has evolved a lot, it is still it's a craft. And the more you refine the work that you do, particularly as techniques have evolved, the better the outcomes are going to be. But the second piece to this is that cancer care, as we have said, is a team sport. And surgeons who are specialists become very well versed in working within the framework of a multidisciplinary team and making decisions in coordination with their patients and families and the team. And one of the things that has happened, and we can talk about this as we discuss the history of surgery, surgical oncology, is it used to be that someone would be diagnosed with a tumor and there would be no question. Surgery was the first treatment in the pathway. That is actually more the exception than the rule in the current era. So often patients are seen by a surgeon, but surgery is integrated into a multidisciplinary treatment package, and often it's later in the care, after they've received some chemotherapy, sometimes immunotherapy, sometimes radiation. So it's really critical as patients and families seek surgical care that they are talking to a surgical expert who is integrated into a team structure and is making the right decision, delivering the right treatment at the right time. Because it's very difficult to play catch up if the treatment is not sequenced correctly.
Yeah, and I guess the one probably big exception to that is patients who present with very early stage cancer, where we're not even sure that they're going to need any kind of medical therapy. And then oftentimes surgery first is the way you go and is the most direct approach. But for anything that's any patient who has a more advanced type of cancer, where you're quite convinced that they're going to need additional therapy, often that therapy is coming first these days. So can you walk us through a little history of cancer surgery? What were the earliest techniques, and how has that evolved? And
Yeah,
maybe
I'd be
you want to,
delighted to. And
yeah,
I think the best way to kind of in a nutshell summarize the history of surgical oncology is we have gone from a mindset of more is more to a mindset of less is more in surgery. And, I think the surgical treatment of breast cancer is really a wonderful paradigm to look at, one that you're very well familiar with, Eric. The early era of breast cancer surgical treatment was defined by a series of progressively more aggressive operations with the best intention in mind. The early surgeons noticed that by removing breast tissue, they could cure the disease in some subset of women, but many women recurred, either in the chest wall or distant sites. And in an effort to provide cure to more and more patients, efforts were made to extend the extent of these operations. And there was a period in the treatment of breast cancer and many other tumors where surgery was enormously painful, difficult, and disfiguring, often involving removal of the breast tissue itself, down to the chest wall, other soft tissues, additional lymph nodes, muscles, and through the really insightful set of clinical investigations, largely led by Bernie Fisher and many others, the realization was made that more surgery or more local intervention did not improve the cure rate. It just resulted in pain, discomfort, long recoveries, and lifetime disability. So that, and I've been privileged in my career to watch this, where, breast conservation therapy became standard, in which, when at all possible, the breast tissue was preserved and lymph nodes would be sampled, to now we've gotten to the point where we not only can preserve the breast tissue itself, many women also have the nipple tissue preserved, which enormously facilitates reconstruction. It's very rare to remove all of the lymph nodes. We have techniques involved to sample a single lymph node, and it is much less disfiguring, and the cure rates are equivalent or better because of the systemic therapy.
And there have even been recent clinical trials in patients with early stage breast cancer not to sample lymph nodes at all. So it is remarkable how the breast surgical group across the country, across the world, has just worked to do less and less and less. There's still, however, for any woman with stages 1 through 3 breast cancer, so anything other than the cancer spreading to distant sites at presentation, there still is a role for some breast surgery. So they haven't put themselves out of business. They've tried, but we still need them.
Well, and I would say that surgery is going to, just looking ahead, going to continue to play a role in the management of solid tumors.
No, absolutely. Listen, we're going to have to take just a quick break, and we will be back in 1 minute, and then we will continue with our guest tonight, Dr. Kevin Billingsley, who is the Chief Medical Officer at Smilow Cancer Hospital.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where patients diagnosed with pancreatic cancer are provided easy access to specialized care, including innovative treatments and clinical trials. Learn more at smilocancerhospital.org. The American Cancer Society estimates that over 200,000 cases of melanoma will be diagnosed in the United States this year, with over 1,000 patients in Connecticut alone. While melanoma accounts for only about 1% of skin cancer cases, it causes the most skin cancer deaths. But when detected early, it is easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilo Cancer Hospital, to test innovative new treatments for melanoma. The goal of the Specialized Programs of Research Excellence in Skin Cancer grant is to better understand the biology of skin cancer with a focus on discovering targets that will lead to improved diagnosis and treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening. This is Eric Weiner. We're back for the second half of Yale Cancer Answers. I'm joined tonight by Dr. Kevin Billingsley, a surgical oncologist and professor of surgery at Yale School of Medicine. So I want to move on and talk about minimally invasive surgery and surgery that uses robotic techniques. I personally had a couple of surgeries over the summer with these techniques, and I couldn't believe the little tiny scars that were used, or the little tiny incisions that led to basically no scars that were used, and how quick my recovery time was. What's happened? I mean, surgery seems like a completely different field than it once was.
I couldn't agree with you more. I think that it has been a game changer in surgery and surgical oncology. And to just trace the history briefly, minimally invasive surgery refers to traditional operations done through smaller incisions to facilitate a quicker recovery and less postoperative pain. This started with laparoscopy approximately 25 years ago, in which the operations were done under video guidance but using straight instruments. What has changed in the past 10 years, and changed very quickly, is the rapid emergence of robotic surgical techniques, which involve the use of wristed instruments working inside the body cavity under 3D optical guidance, with the surgeon sitting away from the patient in the same room at an operating console.
And just to be clear, you said wristed instruments. So these instruments have joints.
Correct. Which expands our capacities to perform delicate and complex technical maneuvers by an order of magnitude. Now, for example, yesterday I did an operation where I removed 80% of a pancreas and spleen, and the patient's in the hospital today and will leave tomorrow. And we can do that because we have magnification with the robot, as well as the ability to suture and manipulate the tissues very precisely under direct vision.
You're looking at a screen the whole time?
You're actually looking in a binocular viewing console, which gives the operator a 3D image of the operative field. It's almost like a virtual reality headset, if you will.
And how do you manage to remove the spleen or most of the pancreas through a little tiny incision? Or in this case, does the incision have to be a little bit bigger to allow for that?
We want the incision large enough to extract the specimen, which we place in a specimen retrieval bag. The incision is expanded slightly, but we actually, once the spleen is in the bag, which is the largest part of this particular specimen, we're able to break it up a little bit because it's not diagnostically useful in this particular operation, so that we're able to bring both specimens out through an incision that's about 2.5 to 3 centimeters long.
And do you ever find yourself having to expand the incision? Excuse me.
Absolutely. One of the things that I do in my practice is robotic liver surgery. And the liver is a pretty big organ. And if it has a big tumor in it, we've got to make a larger incision. But one of the things that is really critical is the location of the incision makes a big difference in healing and postoperative discomfort. And if we can avoid incisions in the upper abdomen and make kind of a limited low abdominal incision, it not only facilitates recovery, it reduces the risk of postoperative hernias, and it's just easier for people to recover. So that's what we do. And operations that we often would have people in the hospital 5 to 7 days, or now a day or two. And one of the things that can make a big difference is if we're trying to get people back to chemotherapy or some other oncologic treatment. Facilitating that also makes a difference.
So I can understand how a young person, somebody who's, let's say, 32, 35 and learning these techniques, can take advantage of all the gaming they did as a kid and use that to their benefit in terms of learning these new techniques. But I dare say you're a few years more advanced than that, and you probably didn't grow up, playing with a lot of video games. And how hard was it to learn to use these robots?
Great question. And it has required a lot of practice, because most surgeons of my generation know the operative anatomy almost intuitively, and we have muscle memory for more traditional surgical procedures. And it does require shifting your perspective to a different view of the anatomy, but nevertheless, thousands of hours of operating in a more traditional setting still is of value, even with a new approach.
And when this first came out, 10 years ago, 12 years ago, what have you, did you end up going and taking courses?
Well, I will say, like many surgical oncologists, I was reticent and skeptical. One of the things that we as cancer surgeons have to always be mindful of is, yes, recovery is important, postoperative pain is important, all of those things are top of mind, but job number one is curing the cancer
and doing a complete cancer operation.
Exactly.
Yeah.
So before jumping into robotic procedures in my arena, I really spent some time watching the field evolve, and I felt like I had to be sure that we could do these operations safely and with equivalent oncologic efficacy to a more traditional open operation. And I think, fortunately, we've accumulated enough data from multiple centers to feel comfortable with that. And it did. Once I made the commitment, it really took several years of practice and working with other surgeons. Some informal courses, but I've actually traveled around the world watching other surgeons do this, conferring with them, exchanging techniques. And it is a relatively small community, and we all learn from each other.
Wow. And this equipment, I assume, is quite expensive to purchase. So is it available everywhere?
It's not available, and the equipment, like all technology, is evolving and improving at a rapid rate. So it does require capital investment from health systems and kind of ongoing capital investment to keep up with the technology. And I'll just say quickly, I'm pleased that Yale New Haven Health System has really made a commitment to robotic surgery and surgical oncology, and we have the latest robots in our fleet that are really great to work with.
And last question on this specific area. How often do you find yourself having to convert a minimally invasive and robotic procedure into an open procedure? That something goes wrong, and the only way you're going to fix that problem is by doing a much larger incision,
Yes.
a traditional operation?
Great question. And it's something that surgeons like myself spend a lot of time thinking about. Well, not very often. I would say less than 10% of my cases do I need to convert. But I think that part of what our responsibility is to select patients very carefully. And some situations just are not safe or appropriate for minimally invasive surgery. The operation will be better, the margins will be better, the control will be better and safer in a traditional open operation. And these are conversations that I have with patients quite candidly. And I think for our audience, I would say, as you talk to a potential surgeon, assess his or her experience, and you should feel good about their candor in discussing how the operation is going to be approached and whether it would be minimally invasive or open. And sometimes a minimally invasive operation is just not appropriate.
Yeah, no, I can really imagine. So related to all of this, and we talked about it before when we were talking about breast cancer, but it certainly is important in other areas as well. Talk to us a little bit about organ-sparing surgeries, and not necessarily just in the abdomen, but more broadly, in the area of head and neck cancer. There used to be these radical procedures that caused a lot of deformity and a lot of problems in terms of people's ability to talk and swallow and eat. And I'm just struck that there's so much attention paid to doing what you were referring to earlier, both doing an adequate cancer operation, but preserving enough organ function so that somebody isn't left so very debilitated.
Eric, I actually think that this is one of the most exciting areas in multidisciplinary oncology. And, as we discussed earlier, I think there are going to be areas where we do significantly less surgery in coming years. Again, I don't think we're going to go out of business, but I think it's going to be in a good way that we do less. And I think, let me just give you a good example. I think rectal cancer in the GI space is a really good paradigm to think of. It used to be that every patient who had this disease had a major operation. We are now finding that with chemotherapy and radiation, we are able to avoid disfiguring surgery in a significant subset of patients and monitor them long term, and only use surgery if they recur or progress.
Dr. Kevin Billingsley is a professor of surgical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.